Thank you, Rose, for throwing in the spanner, because we need to start rethinking all over again. Right, we started off with Charlotte telling us we have a big problem, we need to think about how to look at it. As we look at it, there are people who are talking about physical violence, and there are people who are talking about sexual, intimate partner violence. We don't know who is talking about outcome and what the outcome measures are, and if we're measuring the same thing. We don't know what we're intersecting, because everybody has different definitions. And right in the middle of this, we had 2 definitions, 3 definitions, which are telling us it is true that the evidence that we're talking about is to be rethought, because whatever we call quality may be different depending on what we're saying. The second thing is we've been really pleased throughout the morning saying intimate partner violence is directly associated with HIV, and then a demographic and health survey tells us we've done 10 countries, there is nothing, including East Africa. Everybody who doesn't do numbers, please disregard that for now. Let's try and come to a consensus as to what is it that we're going to tell our governments in terms of how to move on from here. And that will be my first question to all of you, because I have the mic, so I have the ability to commandeer some things myself. And then there's the issue of causality. This causality is, what is causality? What are we talking about? Is the causality of one study equivalent to the other? And are we talking about cohort? Are we talking about different things? Do we have the capacity to be able to address all these things together? And how does that move on to the programming world? As the programming world is going with all the things that we have said, possibly does not work, possibly does not work at all, and yet there is money that is being spent to do this work. So may I give you the floor and get your questions? I think we should take 5 questions per time. I would suggest you introducing yourself, where you come from, and have a very short question or a comment, and tell us who you're addressing that to, so that that person is able to respond to you. Does that sound like right? Okay. I have 2 microphones which are all working, so.
May I start? Hi, my name is Silvia Pasti, again from UNICEF, and my question is for Charlotte. Thank you very much for a very good presentation. It's more reflection. With the men's circumcision as a way of, as a part of, or one way of preventing HIV, I heard, I don't have evidence, but it seems like both men and women feel, okay, so we don't have to use so much now condom, because if the man is circumcised, the risk of getting HIV, it's lower. So I would like to hear your feedback on my reflection, and if you heard about that, and what does it mean in terms of the whole strategy of HIV prevention. And then in terms of, I mean, you clearly showed the relation between the gender inequality and HIV, and that violence starts early in life of girls and women. But also what I know in Uganda, actually there is the social expectation that women have many children, as many as possible, and therefore they should start early producing in their teenage period, start producing and conceiving children. And it's an expectation from men and parents and probably girls themselves. And so I was wondering also how that expectation plays in terms of HIV prevention, even when the partners, there is no violence against partner, still it increases the risk of young girls and young women to get HIV. Thank you.
Thank you very much. That's 2 questions. Can I request that we take a question per person so that everybody has an opportunity to get their question in?
Thank you very much. My name is Karim. I'm a pediatrician. Mine is a little comment, but maybe a question to Rose. It's very difficult situation when you are discussing about screening for HIV in pregnancy. As a pediatrician, my primary goal is to make sure this baby is safe from HIV. And I would put my blinds on like a horse and really don't care about other things. Mind you, I really care about those other things, but I'm just saying for the time being, because my primary goal is prevention of mother-to-child transmission. So I would want her to be screened. Whether she shares with the spouse or partner, and there is partner disclosure of the HIV status or what happens there, sometimes I turn the blind eye. But I have to save this baby. Now you are putting me into a fix. If she says, no, I don't want to screen because I might be a victim of domestic violence and all those things which you mentioned, now I'm concerned about this baby. Now let us work together. This is my view.
Okay, thank you for that. I think it's a comment you might need some responding to. 3, 4.
I'm Beatrice Mulindra from Nordic Consulting Group, and my question goes to Rosa Pondi, and thank you, the presenters, for your very well-researched presentations. You mentioned that you have GBV indicators in the PEPFAR program. So I'd like to hear from you, your experience in terms of collecting data on these indicators, in the sense that how easy is it to collect, and is it reliable, given that sometimes you may speak to this group of survivors of violence, and then next time they are not there or they are not willing to share information with you. And then also, because addressing GBV is a process-oriented, at what level are you placing the different indicators? And then if you find that your respondents are different from the ones you spoke to when you are developing the indicators, what precautions are you putting in place so that as to use that data in a manner which can inform your decision making? Thank you.
Thank you. I'd like to thank the presenters for their informative presentations. We've had a lot to learn from those presentations. However, I have heard the preventive measures and suggestions that you make, but I think one of the things that we need to focus on for Uganda and Africa generally, I think, is the issue of socialization of the women, because this IPV mainly affects the female, because they're the weaker sex in the relationship and all that. So I think we need to pay more if we're going to prevent it in the long run. Like somebody said that it's here, it's a norm, IPV. We need to focus on socialization, because the women of my generation are the future mothers-in-law of tomorrow. And we are the ones who oppress the young girls. You know, you're there telling her, how can you do that to your husband? Because if a woman stood up and said, I'm not having sexual intercourse with this man, because one, he has been away, he left home for a month and now he's back. It happens here in Uganda a lot. And all that he has another partner, I've got them red-handed, and I feel I'm not protected until we go for HIV. Society, like somebody said, in Uganda, it's not really intimate alone. It's not between the two of you. It's a whole society behind you. So I think we need to focus on changing that socialization. The equality between men and women that is being preached should be practiced. When we just talk about equality in words, when it comes to the actions, we are the ones who are pushing, then it becomes a challenge. Then I'd also like to find out from the presenters. Can you just
put it short, please?
Yes. Okay, the study is mainly on Africa, the examples that we've had. How is it elsewhere in the developed world? Is IPV related at all to HIV infection and all that?
Okay, we'll give the panelists opportunity to respond, and then we will ask the next batch of 5 questions. I think there are like 8 already.
Okay, can you hear? Is that working? Great. What a range of questions and comments. In terms of Jessie, first, picking you up about the mixed evidence, I think the evidence has been mixed, but actually it's becoming more solid over time. So the paper that Samuel presented, where it said there's no evidence of association, that was coming from analyzing cross-sectional data. Actually, when you dig into some of those analyses, some of those things, some of the studies that they're drawing on have the methodological problems that I was trying to allude to. And for example, I looked at 5 different analyses of one data set from India, and they all came up with different conclusions. And when you pick out the one that actually did a decent job, it found an association. Because actually, if you start mixing and you go and we're comparing a woman who's experienced sexual violence with a woman who's only experienced physical violence, but treating the one who's experienced physical violence as not having, because she hasn't had sexual violence, she's the unexposed category, you're not going to see an association. But actually, if you say, look, that woman is experiencing violence, we need to compare with somebody who really has had no violence, then you do see the association. And so I think over time, the thinking's getting more nuanced, and actually the most recent paper that I was summarizing, when they look at the cross-sectional data, so including the paper that you saw, Samuel, but also adding on other studies, overall it was still pointing to an increased risk. And then the cohort studies, where you clearly have that cause and effect, they're all very consistent in terms of an association. So I think in terms of that sort of debate, yeah, we do need more evidence, but I think it has been messy, but actually it's increasingly becoming clearer that partner violence is associated with HIV. Your question about, is that the true all over the world? If we're in a setting where HIV infection is mainly driven by injecting drug use, partner violence has a role to play, but it's the role in relation to injecting drug users and their female partners. So it manifests in a different way than if you're in a setting where HIV infection is largely in the general population. If you're in a setting where most of your HIV is mainly amongst sex workers, that it's their experience of violence and their relationships from clients that becomes most important. And actually there might be lots of partner violence happening in the general community that's a problem, but it might not be so closely linked to HIV. So we have to be aware of where is the HIV epidemic, and then what does that mean about where might violence play a role when we're thinking about these interconnections. The issue of causality does make it really tricky, but actually the issue of causality for me, we can get hung up with that, because the issue of not being able to pick out, is it a cause or is it a consequence, basically means it's hard for us to estimate how big is that association, how strong, how important a factor is violence for HIV. But it's an issue. It's an issue because we're trying to provide services to women who are experiencing violence, and we're also trying to prevent new infections, and we know it has a role to play on each side. So actually for programming, I don't think that's so much of a hang-up. When we look at the data from RACI, what's interesting there is, so for Uganda, from that setting, what they estimate is that violence contributes to about 20% of those new infections. So it's one of many drivers of HIV, but it's an important one. They estimate it's sort of 25%. I can't remember the exact number. So I think the evidence is strong. And then, sorry, the specific questions. In terms of male circumcision, I don't know that evidence, but I think colleagues here from RACI who have a lot of experience in doing research around delivery of male circumcision will be able to speak to that better than I would, so I'm not going to attempt to do that. I think the issue around norms and the issues about pressures, there's a range of gender norms that influence behavior. There's norms around the acceptability of violence, about keeping violence secret, about women being inferior to men, that all play a part in supporting violence. The issue about having large family sizes, large numbers of children, is another gender norm that's important. And they're all sort of clustered around expectations in women. So when I'm showing the data around associations with HIV, actually we're not even looking at how those other norms contribute to it. But what it does speak to is all these norms are something that programming has to address. And they're all interrelated. And if we start talking about one, we'll end up talking about all of them, which is all about women's position in society.
Thank you very much, Karim, for bringing up that question and showing how complex it is. It is something that I brought up as a barrier, as something that programs need to think about. Just as the pediatrician is thinking about the baby, you're forgetting that the program is, even when you get that baby safe, you might miss the mother, because the baby is only part of me, and there are bigger issues around. If we are coming up with programs and saying all women must go through screening for something, we have to think about the implications. Because if I am going to come home and be beaten because of your program to make sure that the baby is well, I might just dodge coming to the facility. And at the end of the day, the baby whom you want safe will not be safe because of the implications. So I think the important thing for us as program people is to step back and think about how can we make the best out of what we have? What is it that we can do so as to ensure that the mother is safe and the baby also is safe? So those are things that we need to think about. These are complex issues, and we really need to sit down, look at the data, look at what has worked, so as to make sure that we safeguard that precious baby and the mother too. In relation to the indicators, Beatrice, you talked about the data collection. This is something that I alluded to. The indicators that we have are mainly quantitative, and as you all know, gender issues are mainly qualitative issues. So we may not be able to actually point out to what the problem is, but looking at studies, for instance, the one which I did present, we are looking at cohorts to see the issues around so that our evidence is better and we actually can be able to have causality and explain problems underlying and therefore be able to respond accordingly. So those are some of the issues. Some programs may think, well, because I have these two indicators, I'm doing well, but we take those indicators with a pinch of salt.
All right, thank you very much to the panelists. Since we have roughly about 20 minutes, what I would suggest is take 3 questions from these 2 sets of tables, no, 4 sets of tables, and the other ones for another 3 from the remaining, so that we're able to have covered the whole room. I'm becoming a dictator, but please. Right, any questions? There's a hand there. No, go ahead.
Thank you. My name is Ian Askew with Population Council. I wanted to raise, and this maybe is for Samuel or Charlotte or both, the measurement of violence and the use of the phrase forced violence. Because I'm reminded of research we did more than 10 years ago amongst adolescents in Western Kenya, and looking at the continuum between forced violence, non-consensual, persuaded, sweet-talked, and how the way you measure that and what it means culturally and how it plays out is so important. And I just worry that we get locked into measures because of the necessity of doing the way the surveys are done. And that may be why we're ending up with such variations amongst what we're seeing. Because when you think of forced violence, you tend to think of physically forced violence. And that's often the similar sort of response to someone who was sweet-talked or persuaded or it was negotiated in some way. And I think that whole area of non-consensual, consensuality, and particularly in an intimate relationship, is so critical in what the implications are for what's happening in the sexual relationship. That it's something, and I'd be fascinated to hear about experiences from the panels and others about approaches to getting at that nuanced measure, so that we don't just rely on forced violence versus non-forced, and it's too big a gulf to leave as it is. And I think it'd be good going forwards that we can try to tease this out a bit more.
I would like to commend the presenters for very elaborate presentations. My name is Anna Maembe from Tanzania. I work with the Ministry of Community Development, Gender and Children. What I would like to say is that GBV, where you have IPV as a subset, is a real challenge at the moment. It's both a health and a human rights issue. So we have to address it in whatever format. But I have two issues which I'm trying to think aloud. When you look at, say, IPV we are talking about, I'm happy that the silence around the problem is now, I wouldn't say it's coming to an end, it's now being addressed. Because if we can have data from global, maybe cohort, or very small projects, then we are starting to address the problem. But my concern is the quality of data. One, we are talking of issues related to quantitative and qualitative data. Is it possible for us to start by looking at the standards? How do we collect the data so that we can compare? We are talking of region, East Africa. Is the study done in Kampala comparable to that done in Mbeya? Can we say we have the standards? So I think it's good because we are opening up, we are breaking the silence. Let us look at the standards. But my second concern is that GBV, with its subset IPV, is socio-culturally constructed under norms and practices. And this sometimes is very, very difficult to get data. How do we start? Maybe from the qualitative, so that it can inform quantitative data collection. I think that is also very important. But I would like to share one experience. Thank you to the UNICEF representative who talked about children. I'm not saying it's too late for us, but I think it's good for us to address the youngsters, because those are the ones who are going to be mothers and mothers-in-law soon. How are we really putting up the stage for them to come on board? In Tanzania, we did our violence against children, the national survey, in 2010. We started in 2009 up to 2010. But because of the appalling results, it took us as a ministry 10 months to publish, to get the clearance to publish the results. Finally, it was done. And I'm proud to say, I will always come up that it's very appalling, but we are proud that the research, the study was cleared. So we have to do the same with violence against women. We must start somewhere. Can we get the baseline from the region, from the 5 countries? I'm sorry that we are starting with 3. We should say 5, so that we can get the standard to compare the 5 countries. And let me share one example. We were in Swaziland looking at violence against children, and we got an example from South Africa. 1 man can, looking at violence against children. And it's a South African model, 1 man can, and they are really showing that men can do it. What I would like to say is that let us from the onset involve both men and women. Thank you.
Thank you very much. Is there a comment or a last question from the middle table, or should I shift to the other one? Okay.
My question is addressed to Charlotte. You gave us evidence about the relationship between intimate partner violence and HIV/AIDS. But I was wondering, because most of the studies that you've provided are in high HIV prevalence areas, do you think there could be a difference if you looked at studies of low prevalence areas in Africa? Because when it's a high prevalence area, there are other contextual issues. Poverty is there, other issues are there. So would you think there could be a difference if you looked at studies maybe from West Africa where the prevalence is quite low? I'm Stella Nema from Makerere University.
Thank you very much. Can we just shift to the other side so that we take all those questions? When they respond, we go out to lunch, please. 3. And please make them short.
Okay, thank you. My name is Lydia Mungera, and I come from the Mamas Club Network, and we coordinate the Uganda Men Engaged Network too. And we are part of the One Man Can campaign. One of the things that I think is very clear is that too many studies, or so many studies have been done and they're not harmonized. And for example, there's a condom study as well, which actually has clear issues which need to go into what we are discussing. And we've also realized that in the work that we do, because we work with mothers in family support groups at EMTCT sites, but we also have the Men Engaged Network, and we work with peer mentor fathers as well. There's a big gap of lack of knowledge and information amongst the different actors. And we need to start from bottom up, but we need to talk about grassroots, we need to talk about program implementers, and we need to talk about policy. And how do we bring these together, all these different players and actors, in order to make any difference in what we're talking about? One of the things that's really very clear is that as much as the Ministry of Gender is working out on different groups, and PEPFAR has, thank goodness, come up with a gender audit, how do we push these into real policy frameworks that already exist within countries? Because each country has got policy frameworks, but we seem to have that little gap of information and knowledge, and also putting it all together. And I really think that bringing the actors together is what is missing here.
Just already, can you pass on the mic to somebody else, please? I'm sorry.
Thank you. I'm called Judith Nakalembe from the Uganda Women's Network. My area of discussion would be more on prevention and response if we were to prevent intimate partner violence. I appreciate the fact that we have laws in Uganda like the Domestic Violence Act, which is providing for different forms of violence. But when you look into the jurisdiction of, for example, if I talk about the magistrates or jurisdiction of which courts should handle such cases in ensuring that these victims of sex violence, you realize that the most rural person, like for example the districts up country, lack like magistrate courts. When we look at magistrate courts, you realize, like, for example, if I'm to talk about Busoga region, where UONET is having shelters, districts like Kamuli and Namtumba lack chief magisterial courts. Chief magisterial courts. The courts are not gazetted into chief magisterial courts. We have the courts, yes, we have like G2 magistrates, we have like G1 magistrates, but the nature of violence we are receiving are in terms of sexual violence. We have cases like rape, defilement, and such magistrates do not handle such cases. It implies that these victims or survivors have to travel as far as Jinja or Iganga so that their matters are heard. But when you look at the level of poverty, it's really causing frustration of many of these cases. Now, if I give an example of Kamuli, we have one grade 1 magistrate. The one grade 1 magistrate is adjudicates over cases from Buyende, cases from Kaliro, and he's overwhelmed. His interest in FCC courts, FCC or family courts, where victims of domestic related issues are heard, is low because he's looking into criminal and civil cases, implying most of the survivors or victims of GBV are left out. Now, what is UONET trying to do?
Can I please intervene because you're taking a little bit more time? Can you close that question or comment? So that we can move to the
then when we
next
look
person?
into addressing, there is need to strengthen the referral pathway. You realize that in many of these rural districts, doctors work half day, then access to PEP. You realize that the health centers, like Health Center Falls, there is no PEP, there is no Postina. Now, if we are to address intimate partner violence, really, for sexual violence, there is something that has to be done in form of advocacy and ensuring that at least.
Thank you. The last one, please make it very short so that I do not have to cut you. We're just about going for lunch.
Thank you very much, Chair. My name is Dina Akalo, and I'm coming from Uganda Joint Christian Council. In line with what someone said there about bringing the men on board, recently Uganda Joint Christian Council carried out a study on the magnitude of gender-based violence. But one issue came up, that the men are also suffering. But I don't see how we are bringing them on board, and it's mainly because of the cultural aspect that men are supposed to be men, but they're suffering in silence, and the magnitude is really big. So how do we encourage the men to open up, you know? How do we encourage the men to open up? And you know, we are working with the church structure. We are working with the church structure, and when we had a focus group discussion with the men, they said, yes, it's there, and they're suffering, but men are taught to be men. So how do we, then also, the institutions, we are also working with institutions, universities, there is also no policy on that.
Sorry, I'm cutting you out. We'll take a response to those questions, and I request you to be really short and sweet. No, I'm not taking an additional one. That was 6 questions that I said we should. I would request for us to continue networking outside and address whatever additional issues you have with the person who is sitting at the panel. Thank you very much.
Thank you so much. I feel probably I can attempt to respond to. One is from, I didn't get the name correctly, from Pop Council. You're kind of wondering about the measurement of violence, and when are you kind of convinced to say this is violence and when it's not violence? Because the way you saw looks like there was no consensual. Looks like there was some element of agreement. This is a tricky area when it comes to sexual violence, especially in this kind of setting. And it emanates from, when you look at the courtship in African society, when do women say yes, and when do women say no and mean no? But bottom line, what we know, when these women are asked about if somebody did that, she agreed or she didn't agree, we take that she didn't agree as this is really no. And she never liked about it. She never liked anything about it. That she could, you know, kind of, that should never happen to her, but she had no means, and that happened to her. So I know there's a problem around that one, and men always justify by saying, you know, I can really figure out if it's okay or not okay. The other thing, actually, Mama from the ministry in Tanzania talked about the quality of data that we do, and if we use some kind of a common measurement to measure violence or not. And from what I understand, like the 2 studies that were done in Tanzania, the WHO Matkanti study and the DHS, that for the first time made a module on gender-based violence, they use CTS tool, which is kind of common tool that is being used to measure this violence. But I agree with you when it comes to engagement of stakeholders when the research is being conducted, for these stakeholders to understand what is it that they need to do, whether it's a policy, whether it's intervention, then they're able to really address like the model that the VAC survey was done in Tanzania. That was really good model, and I know a lot of countries, you know, in Asia, they came to learn about that model for government and stakeholders engagement when it comes to research and, you know, break the silence of violence. So maybe I end there and give a chance to other respondents.
Thanks, Samuel. Yeah, I mean, to add in terms of measuring violence, when we're measuring exposure to violence, we use very behaviorally explicit questions. Have you been physically forced to have sex? So within partnerships, it tends to be there's 2 or 3 questions that are asked around forced sex. One is, have you been physically forced? Another one will be, have you been pressurized? And so then we can look at that data separately. When it comes to adolescents, commonly what's used is a few different questions, 2 or 3 questions. Again, sometimes it's a bit hard about what does coerce, and the wording is sort of evolving, I think, as we learn. I think what's interesting when we look at the associations with HIV is, you know, maybe we're measuring things that somebody wouldn't say that's not really forced sex, but actually we see an association. It's coming out as an issue. So actually, despite our measurement challenges, what we see is there's impacts on a whole host of health areas, despite our challenges in measurement. In terms of quality evidence, I think as long with the sort of, I think there's quite a lot of standardization about how violence is measured. The challenge is then making sure that interviewers are trained properly, that they're non-judgmental, that the woman feels comfortable to disclose. So I think that's the big issue in terms of variations, is if the level of support that interviewers are given, because that's what you're asking somebody in private a very sensitive question, and if the respondent feels comfortable, they'll disclose. If they don't, they won't. In terms of the whole thing about Stella's question about would violence be so important in lower prevalence settings? I think in somewhere like West Africa, it's going to be more linked to where HIV is. So it's going to be linked to more sex work, transactional sex, where we're seeing higher levels of HIV infection. And so it might be less of an issue in other populations in relation to HIV. But I mean, what's interesting in India, which has a much lower prevalence here, is you see a cohort study there found an association between partner violence and STI infection. So the same phenomena is happening, I think, all over the place. And lastly, in terms of interventions, I think that's where the evidence is weakest. And so we're starting to get these evidence syntheses, but they're in very early days. And a lot of the current evidence syntheses is around, do these interventions prevent violence? Actually, what we need to know how do we prevent violence? And actually, we're starting to learn that actually we can prevent violence, and there are community interventions that can prevent violence. There are interventions that work with women and men, seem to be most effective. Interventions that empower women economically and socially seem to be very promising, and actually might give us a way of scaling up prevention by, if we could integrate development initiatives with gender programming, that might be effective. I think the role of the health sector is incredibly important. There's debate about the role of screening, but actually I think everybody's agreeing that health workers should be asking. It's whether they ask every woman or whether they ask when they think there are issues. And then it's how do we support health workers and other people to respond appropriately. Not only to prevent future violence, but also to reduce the impacts of that violence, because that's what we're talking about as well, the role of the health sector. You know, that's important.
Take home. Two things. Oops. Take home, two things. There is an association between intimate partner violence and increased risk for HIV. That's what I heard, right? The second one is the quality of the evidence is solid. However, we need to build the capacity so people are able to do things correctly and that they have proper documentation so that we can track what is it that was done and whether it was standardized. Lastly, multisectoral coordination and intervention for intimate partner violence is key for the HIV response. Thank you very much and have a good lunch.
Thank you very much. Again, we put our hands together to thank Charlotte, Samuel, Rose, under the stewardship of Jesse. Thank you, and thank you all for being good listeners. One of the things that is coming through is that there is competing evidence, and I think that having competing evidence is all right. The challenge is having the capacity to sieve through this competing evidence and come to a consensus. And that's what academies do. The academies act as a high court of science. So we convene all the competing evidence for us to be able to provide a consensus that will then guide policy and programming. So do bring this on board so that at the end of the day we can have something. The other thing is that as the presenters are making, it brings to mind for all of us what we know, and would like you to write what you know or what evidence you have and bring it on board. We may not have the opportunity to present it, but let us know so that we can upload all this and then share it, because this is a sharing process, so that at the end of the day we can inform the whole process. There will be a press conference. I would like to request that the president of the Academy, Uganda National Academy of Sciences, stays behind. Tina, stay behind. We've asked Patrick to stay behind, and Jackie, my co-chair, will stay. The rest of you, bon appetit. Interact more, and then we should spend just under an hour because we ate into the time for lunch. The lunch is going to be served in the Victoria restaurant. When you go out, you go straight and you sit. Everybody has a coupon. If you don't have a coupon, my colleagues are here to make sure that they give you those coupons. Back here at 1:30. On the dot to go on to the next session. So lunch is served. Enjoy.